upper abdomen, no organomegaly, and it was normal. Coming to ENT examination, nose, nasal bridge, dorsum columella, ala, and on both sides, tip of the nose, all normal. External examination, core spatula test was normal. On anterior rhinoscopy, nasal cavity, left side deviated nasal septum, middle turbinate, diagnostic nose endoscopy, grayish-white sloughed mucosa in the left middle meatus was seen. Nasal sinus tenderness, left maxillary tenderness was there. Coming to posterior rhinoscopic examination was normal. Ear and throat examination were all normal. CT scan of paranasal sinuses showed deviated nasal septum to the left, moderate to severe left maxillary, left ethmoid, and left frontal sinusitis. Middle mucosa thickening in the left sphenoid and right posterior ethmoid. Investigation, blood routine, HB 16.8 gram per DL, total count was 28,000 per cubic mm. Blood sugar was 374 mg per dl. Urine albumin was present. Sugar was 1.5%. Ketone bodies was present. Pus cells were seen. And culture sensitivity was sterile. On KH mount of the middle meatus, filamentous branched hyphae was seen. Chest X-ray showed opacities in the upper and the lower zone of the, upper and the middle zone of the left lung. Coming to the provisional diagnosis, it could be mucormycosis of the nose. Differential diagnosis is suppurative sinusitis and aspergillosis. Final diagnosis, we came up to diabetes mellitus with left nose cavity mucormycosis, left lung upper lobe pneumonia. Treatment, patient was admitted to ICU and was given following treatment. Plain insulin injections subcutaneously on sliding scale of 8 hourly. Injection amphotericin B 0.5 mg per kg in 250 ml saline over a period of 4 to 6 hours once a day. Antibiotic cephaloperazone 1 gram intravenous twice a day. Surgeries under general anesthesia was done. Left septoplasty along with ethmoidectomy. Frontal maxillary sinus clearance was done. Coming to the discussion. Diabetes mellitus and mucormycosis. Diabetes mellitus, it should be managed by giving insulin administration and diabetic diet. Patient should be treated and should be in follow-up for the medical care regularly. If patient fails to do so and diabetes is not controlled, then it can manifest into intercurrent infections like pneumonia and sinusitis. Coming to mucormycosis, it is a fungal infection mainly caused by filamentous of mucorales, orders of class Zygomycete. Predisposing conditions is diabetes, neutropenia, metabolic acidosis, immunocompromised patients, poor nutrition, long-term use of steroids and certain antibiotics, and burns. Mode of infection is inhalation, ingestion, and traumatic inoculation. Pathogenesis, the most common form of mucormycosis is rhinocerebral, and most rare type is rhinoorbital. It invades blood vessels, which results in the formation of blood clots and surrounding tissue death by loss of blood supply. It is inhaled or ingested. Spores produce infection mostly in sinus, orbit, brain, gastrointestinal tract, lung. Fungus may cause tissue necrosis, invade arterial walls, cause infarction, venous thrombosis, penetrate orbital wall and cause cranial vault. Clinical presentation of mucormycosis in nose and paranasal sinuses. Onset with stuffiness of nose, epistaxis and facial pain. Later swelling, chemosis and ophthalmoplegia. One-sided headache along with fever and confusion. Grayish-black eschar on the nasal turbinates. Other features of mucormycosis is poor prognosis, high rate of mortality to 30 to 70%. Complications mainly include blindness, blockage of the vessels and infarction, nerve damage. Hence, diabetic patients with ketoacidosis are likely to in a risk zone for mucormycosis and should be treated accordingly. Diagnosis in the early stage and timely treatment has better prognosis. I would conclude it by take-home message, that is, in case of uncontrolled diabetes, if the patient has persistent headache, check for sinusitis and fungal sinusitis and save the patient's eye as well as patient's life. This is the inlet admission ticket of the patient. Thank you.
No, I congratulate you for your enthusiasm, absolutely. These are early days, but take our suggestions. Now, in a presentation of mucormycosis, you told mostly about mucormycosis and diabetes. Yes. It is your experience with mucormycosis, that's what we look for here. You didn't show any endoscopic pictures. You didn't show any CT scan. When a case report, you are presenting a case report, your case,
yes, sir.
your findings in your own investigations, your modality of treatment, your surgical findings, how you cleared them, and you said it is orbital. Did it extend beyond the periorbita or the orbital septum? Did it go, or it was only compressing? Was the vision improving following that? How was the vision? Was it improving in your patient?
We changed the top.
No, that's what I'm saying. No, whatever it is.
Yes.
You understand what I'm saying?
Yes, sir.
It should not be like a class on mucormycosis.
Yes.
It should be your experience of a case with mucormycosis.
Yes.
So they are all missing in it. And the other aspect is that when you have extensive mucormycosis, actually when I read the topic, what I expected was you are going to show me the difficulty you experienced in removing the entire fungal debris, which is extremely difficult. When you go on doing ethmoidectomy, skull base comes, that can get eroded, anyway lamina is eroded. How you are going to remove it without damaging the orbit? Suppose you have gone into the sphenoid sinus, how you are not damaging the optic nerve? Those are the important points for a case report.
Yes.
You are telling mostly about mucormycosis. There was nothing left for me to ask anyway. Okay.
Yes.
Did the patient regain vision?
No, sir. I was not affected. We changed the topic to mucormycosis of the nose.
Hello. హలో శంకర్ భాయ్ మనకి ఏం లేదు ఇక్కడ జడ్జిగా పిలిచారు అయిపోయింది లాస్ట్ పేపర్ బయలుదేరి రావడమే పేపర్ యు అండర్స్టాండ్ వాట్ ఐఎమ్ సేయింగ్ ఓకే సో డిడ్ యూ గివ్ amphotericin B to the patient?
Yes, sir.
Were there any complications? Elderly patient with such diabetes, you are giving amphotericin B.
Yes, sir.
Did you encounter any difficulty in such patient?
We followed up till 1 week, sir. He was
No,
all
that's
right.
what I'm saying. So this is the direction in which we expect you to present it.
Yes.
Okay, you understand?
Yes.
So you made it
Mucormycosis.
nose. Okay, you made it mucormycosis of
Yes,
nose.
sir.
All right. But had it extended to orbit, it adds a few marks for you. The more extensive the tumor or condition, the more marks you get. Okay, right. Go. Excellent. Right.
Thank you, sir.
Any other questions?
First presenter? Not there.
So, yes, sir. We called